Hey friends, thank you for joining me. Today we're going to talk about gingival defects and how you as a clinician, whether you're a general dentist, you're a periodontist, or a hygienist, or anywhere in between, how you can be identifying soft tissue defects in your patients at a higher rate and recommend the right type of treatment for them. So let's get started. I've got a couple cases that we're going to walk through, and at the end of it, I think you're going to be a little bit smarter and be able to be more confident in recommending treatment when it comes to soft tissue for your patients. Let's head into the presentation. I got a couple cases here to show you, and we'll get started. All right, so when it comes to soft tissue defects, what I want to talk about today is what to look for and when to intervene. So today we're going to just do a quick overview of gingival defects, right? What they are. I know we probably learned these in dental school, but we're just going to go over it again because, it's important and it's always good to have a little refresher, right? We're going to talk extensively about when to intervene. So you see a soft tissue defect in your patient tomorrow. What are you going to recommend for your patient? Are you going to intervene? Are you going to recommend treatment or a referral? Or are you going to say, we should probably watch that? We'll talk about how to kind of approach each one of these. And finally, towards the end, we're going to go through just quickly some soft tissue grafting options, and I'm just going to show you some of the cases that I've done just to kind of explain that to your patients. Again, we're just going to talk the basics, nothing too crazy. And then finally, we'll wrap up with a couple of case examples to kind of help cement everything we've talked about. Would you treat, would you not, that kind of thing. So today, what I want you to walk away from this presentation is knowing a couple things. First off, knowing how to spot gingival defects in your patients. So you have a patient in your chair tomorrow, you are able to look at them with a critical eye and look at that soft tissue and be able to determine, is there a soft tissue defect here that I need to be aware of and I need to educate my patient on. Second thing is I want you to be confident in recommending treatment. When and why would you recommend a treatment? And also when to say, I don't think that's necessary. I think a lot of times we're just taught in dental school about these soft tissue defects and never really taught when to refer, when to treat, and when not to. So hopefully this provides you a little bit better framework for that. And finally, I just want you to be able to understand and be able to explain the basics of soft tissue grafting to your patients. The reason this is important is because you might not be actually the one doing the soft tissue grafting, but you're very likely going to be referring to someone like me, a periodontist, who's going to do the grafting. And I will tell you, it's a very big difference when a patient comes to me with at least some knowledge of what's going on in their mouth and maybe a little understanding of what's happening or what the next treatment could be. It just helps that conversation be much more rich with the patient when I do that consult with them. So I think it's important for you to understand what that is so you can, at least at a high level, explain that to your patient. All right, so let's get right into it here. We're going to go through a gingival defect review. We're not going to go through the histology, don't worry, anything like that. So a couple things, right? When we look at a gum tissue, these are the things that should be coming to mind. First off, mucogingival junction here, kind of in the yellow. It's the junction or the separation or the demarcation line between the keratinized tissue, sometimes also called attached gingiva, and the alveolar mucosa. So you can see this nice line here. Most patients it's pretty well defined. Sometimes it's a little harder to see, but you see everything coronal to this line is what we call keratinized tissue. You can see this nice band of pink tissue. It's a little more pink. Oftentimes it's stippled, doesn't have to be, but typically it's kind of stippled. You see these little dots in the gum tissue here. This is what we call keratinized tissue. It has keratin inside of it. It's much more durable. It's also called masticatory mucosa. It's right around the teeth. It's leathery. It's thick. It's durable. It can take forces of our chewing, right, of our food, but also toothbrush abrasion and things like that. It's much more durable to that type of force. Apical to the mucogingival junction, something called alveolar mucosa. This is the more red tissue. It's flexible. It has different types of collagen in it that make it stretchy. It's honestly what allows our cheeks and our lips to be able to stretch and move around. This tissue is good for that aspect. It's not connected to the bone, however. It's not attached to the bone, and it's also less resilient to trauma, whether it's from eating or masticatory forces, right, or from toothbrush abrasion as well. Now, we know the different types of mucosa here, generally speaking, right, but we have to understand the tooth anatomy around our gingival mucosa and gingival anatomy. So right here in the green, you can see here I've highlighted the root surface, and this is a case of recession, which we're going to talk about next. And we can see the CEJ, the cemento-enamel junction right here, and the transition to the root surface, kind of this little triangular portion right here. Now we can see how there's a difference in the width of the keratinized tissue in this area right here, right? The distance from the free gingival margin to the mucogingival junction is maybe 1, maybe 2 millimeters at the most here, compared to on the mesial aspect of this tooth, the distance between the mucogingival junction and the free gingival margin is obviously much greater. These are types of things that we want to be looking for, is the width of keratinized keratinized tissue, as well as any sort of recession, any sort of root formation or root forms that we can see in the tissue. I'm getting a little bit ahead of myself, so let's get to the next slide. We'll talk about some of the defects we can see now that we understand and just have a refresher on the anatomy. Gingival recession, right? I think we all know recession when we see it. This is a picture of it down here at the bottom. The definition of recession, right, is the apical shift of the gingival margin with respect to the CEJ, right? So basically, gingival margin should be at the CEJ or a little bit above the CEJ in health, and in recession, we see that the root surface becomes also more visible as the gingival tissue moves more apical. That's the definition of recession. What causes recession? Well, a couple different things can cause it. Not going to get into a lot of detail here, but it's important we understand a few of the reasons why. Number one reason is anatomic factors. So the alveolar bone that is right around the tooth, especially on the buccal aspect, there can be a dehiscence there. There can be a lack of it, or it can be super, super thin. The reason that causes recession is because there is a lack of blood supply from the bone that's nourishing the gingival tissue in that area. When we have a lack of blood supply, a lack of nourishment, any sort of trauma or insult to that tissue can cause that tissue to start to migrate apically, causing recession. Physiologic factors are another thing that can cause gingival recession. Orthodontic tooth movement is a great example of this. As we move teeth orthodontically, especially when we move them buccally or outside of the bony housing, whether it's buccal or lingual, that thins that bone or almost completely removes the bone in front of that tooth. And that, again, allows for gingival recession because there's a lack of nourishment, a lack of support for that gingival tissue. So anatomic factors, physiologic factors kind of tied together with respect to the bone around the tooth, specifically on the buccal, that when it goes away, it causes recession. Pathologic factors are probably the thing that we think of the most when we think of what causes recession, right? Toothbrush abrasion is probably the biggest thing. If I was to ask you what causes recession, most clinicians are going to say, oh, well, brushing your teeth too hard, right? Brushes your gums away. We tell that to patients a lot as well. And that certainly can be the case, right? We can have toothbrush abrasion, flossing, piercings, whether it's lingual piercings or labial piercings can sometimes cause that. Direct occlusal trauma, think about a really severe underbite that can sometimes cause that as well. And, restorations can sometimes cause gingival recession as well, as there's some bacteria and some inflammation right at that restoration margin. Speaking of bacteria and plaque, bacterial plaque actually can also cause recession, but it really is only going to be able to cause it on the buccal tissue. Now, we've got to be careful here that we don't mix this with bacterial plaque that causes periodontitis. Periodontitis manifests itself right with interdental or interproximal attachment loss, right? So basically bone loss in between the teeth. If we see that, that's actually periodontal disease, not just bacterial plaque that's causing a recession. There's a difference there. It's minor, but it's important to remember. So when we are understanding the etiology of what's causing our recession, we need to make sure that it's not periodontal disease, because periodontal disease can cause recession. It causes the bone to go down interproximally and sometimes on the buccal and the lingual, which can also lead to recession all the way around the tooth. If we're only talking about bacterial plaque just on the buccal and a recession just on the buccal, that might not be periodontitis, that might just be bacterial plaque that's causing recession. So we talked about recession. That's one of the gingival defects that I want you to be able to understand. I think we all can see that, right? When we see a patient and they smile, as dentists, as hygienists, as assistants, right? We see that, we think we can see and zero in on that recession. Here's another thing that maybe you might not be thinking about a whole lot, and something I would really love for you to be more aware of with your patients, and that is the keratinized tissue width. Now, the definition of keratinized tissue, we've already kind of talked about it with our anatomy review, right, is the measurement of the tissue width between the free gingival margin and the mucogingival junction, right? So this blue line right here is the measurement from the free gingival margin to the mucogingival junction. We see that in this case, we have a very wide band of keratinized tissue. Now, there's a very controversial statement that I'm about to say, and that is that the minimum width of keratinized tissue that we want for our patients is 2 millimeters. We want at least 2 millimeters from the mucogingival junction to the free gingival margin. So right here, we want that at least to be 2 millimeters. Now, is that proven in the literature? Is that a consensus across the entire board of periodontology and dentistry in general? No. There are several studies, and this is why there's an asterisk here at the 2 millimeter mark here. There's several studies that show that actually it doesn't matter how much keratinized tissue you have around the teeth. There are some studies, however, that advocate for a minimum of 2 millimeters of keratinized tissue. These studies investigated patients, and they found that if they had at least 2 millimeters of keratinized tissue right around the teeth, that they were more resilient to infection and periodontal disease and recession. So We use 2 millimeters kind of as a cutoff. Is it a hard and fast rule? No, and we're going to talk about that in just a little bit. But we can see a big difference here between a wide band of keratinized tissue, and in the bottom right-hand side here, we can see an example of a patient with minimal keratinized tissue. We're going to see some patients in the next couple slides here with no keratinized tissue around their teeth. And we're going to see what can happen if we don't have that. When you're looking at a patient, we've already talked about recession, right? I want you to narrow in on that. But I also want you to be thinking about keratinized tissue and look at the distance between the free gingival margin and the mucogingival junction. So when we talk about minimal keratinized tissue width, I've kind of jumped ahead of myself here a little bit. When we don't have a good thick band of keratinized tissue, what can happen? The first thing that can happen is we have an increased recession risk, right? And this is because the tissue that we have, which is alveolar mucosa, if we don't have the keratinized tissue, we end up just having alveolar mucosa. That tissue is less resilient tissue. It's more prone to recession. It's more prone to trauma, like from a toothbrush or from masticatory forces. It's also likely to exhibit recession with orthodontic treatment as well, right? So if you don't have a good thick band of keratinized tissue, if you start moving those teeth buccally, that very thin amount of keratinized tissue that you had to begin with is going to likely be just completely obliterated when you start moving those teeth buccally. And that's just what we've seen clinically and in the literature. The other thing that is actually most important to me when it comes to the minimal keratinized tissue is the uncontrolled inflammation risk. And this gets back to a couple of the studies that were done previously that were advocating for the 2 millimeters of keratinized tissue. They found in these studies that patients who don't have 2 millimeters of keratinized tissue, they were unable to maintain and keep these areas clean with minimal keratinized tissue. They found that these areas bleed when the patient brushes. It accumulates plaque. It's often sensitive to brushing. You can see some examples of this here at the bottom. These are all of my patients who have basically almost no keratinized tissue at all. And you can appreciate here in the bottom left, you can see that there's plaque buildup. This patient complains of sensitivity and bleeding every time she brushes here. This patient here, he's had this issue for a long time. You can see actually there's some keratinized tissue here from a previous free gingival graft, but you can see right here, there's just no keratinized tissue, a lot of plaque buildup. Same thing here, this tooth actually was moved orthodontically, and you can see that all these other teeth, there's almost no keratinized tissue here at all. And unfortunately, we see a pretty nice recession that's starting to form around this tooth in particular. Why is it this tooth and not the other teeth? That's probably an anatomical issue. If I took a CT scan, I'd probably see a little bit more bone around these teeth here compared to this tooth. We do see some super eruption, so that's probably playing a role. But we can see and appreciate that in all three of these examples, a lack of keratinized tissue for these patients makes it less easy for them to clean, more prone for infection and inflammation, and also more prone to recession. All three of these examples have recession in combination with a lack of keratinized tissue. So that's why it matters that the keratinized tissue width is controlled. So minimal keratinized tissue width, I'm going to spend just a little bit extra time because it's not something that we spend a lot of time talking about. Is a patient who walks into your clinic, right, and sits down in your chair, if they have less than 2 millimeters of keratinized tissue, is that pathologic, right? Are you automatically telling them that they have a problem? The answer is no, right? There are many patients who are walking around right now with less than 2 millimeters of keratinized tissue around their teeth, and they're doing just fine. They're able to keep it clean. There's no progression of recession. Everything's great. So that lack of 2 millimeters of KT doesn't mean that it's necessarily an issue, but it's something to be watching for because we know that these patients are at higher risk for future recession, uncontrolled inflammation, things like that. And so when does it become an issue, right? When should you, as a clinician, start to have some red flags go up when you see a lack of keratinized tissue in your patient? A couple things here. Number one, prior to orthodontic treatment, right? So if a patient comes in and they says, hey, I'm about to go get ortho treatment, and you see that there's no keratinized tissue on the buccal of those mandibular incisors or anywhere else where they're going to be doing treatment, that should be a clue to you to say, hey, you know what? Love that you're doing ortho treatment. We might want to get you to see a periodontist first to make sure you have good, adequate, thick tissue so that when we do the ortho treatment, we don't cause a gum issue down the road, right? Your teeth might look great and they might be aligned well, but they're not going to look good if there's recession or if you're not able to keep these areas clean. So a couple things to keep in mind with respect to ortho treatment and the lack of KT. When the patient also comes in and they don't have a lot of KT around their teeth and they're unable to keep that clean, just like we saw in these previous examples, that's something you need to be concerned about as well. And then finally, when there is a sign of recession progression, when that recession continues to get worse, that is a time when you need to say, this is an issue that we need to take care of and not just watch. It's becoming an issue, and this is something that we need to take care of. All right, so let's just review real quick: recession and KT, right? These are the two things that I want you to be thinking about and watching for now in all of your patients, whether it's a periodic exam, a new exam, a periodontal exam, doesn't matter. Be thinking about these things and be watching for them in your patients. So recession, right? We talked about that as a migration of the gingival tissue apical to the CEJ. We start to see that root surface. It can be caused by periodontitis, or it can be caused by other factors. And we talked about that. It's good to understand and distinguish which disease is causing the recession. KT width, less than 2 millimeters, right? That's the other thing that we talked about here. We want to make sure that we are addressing the KT width prior to ortho treatment. Inflammation and plaque accumulation, you see it on the patient and they're not able to keep this area clean and it's bleeding all the time. It's sensitive to the patient. Or if we see that there's a lack of KT and we see progression of recession. The recession is continuing to get worse. These are times that as a clinician, a red flag should go up and say, hey, there's an issue here and we should probably be addressing it. All right, so let's talk about when to intervene. We've already kind of covered it a little bit, but you're gonna see patients with recession. You're gonna see patients with a lack of KT. When do you say, okay, we need to treat this? Or when do you say, there's an issue here, but we don't necessarily have to treat it. And the patient is looking to you as the first line defense to make sure that they're getting the best treatment and the best recommendation. So let's make sure you're confident in understanding what those are so we can give the patient the best care. So let's look at a couple cases here. First off, some of the basics when it comes to intervening, right? I get this a lot, and I put this in here because I bet at least half of my patients who come in with recession, they tell me this exact thing. Doc, I'm worried about my recession because I don't want to lose my teeth. Patients think for some reason that when the teeth get longer and they have gum issues and they have recession, that they're going to lose their teeth. We need to make sure that we dispel this myth. And you can read directly from Cordellini 2018, this publication that was part of the World Workshop that was put together. The development and progression of gingival recession is not associated with increased tooth mortality. It's important to tell a patient, just because you have recession, that doesn't mean that that tooth is going to be lost very soon. Now, they might have recession due to periodontitis, and they can lose teeth due to periodontitis, but strictly recession, especially on the buccal aspect of a tooth, they're not going to lose a tooth due to recession. So it's important to tell a patient that, because a lot of times they think, I've got to treat this or else I'm going to lose my tooth. No, the actual answer is you're not. Now, there's other reasons to treat recession. I'm not saying we shouldn't, but we also should make sure that we're not advocating for treatment for something that actually isn't a problem. You're not going to lose a tooth due to recession. We got to make sure patients understand that. They will lose a tooth due to interproximal attachment loss, which is periodontitis, right? So we obviously need to make sure we understand and differentiate between the etiology of why are they losing the gingival tissue around their teeth. So this is a really good example here in this picture here, recession as a result of periodontitis in the top picture. You can see clinical attachment loss generalized on all of these teeth. The bottom looks exactly the same as the top. Interproximal all the way around the teeth. We can see the root surface. There's horizontal bone loss. This was caused by periodontitis. Yes, this patient has recession. Yes, this patient is more likely to lose their teeth, but not due to the recession. It's due to the periodontitis. Contrast that to the bottom picture here, we see recession, right? But this recession wasn't caused by periodontitis. It was very likely caused by toothbrush abrasion. We don't see any interdental clinical attachment loss. And if I showed you the x-ray, the bone levels look great. This patient is not at risk for losing this tooth due to recession, or even due to periodontitis, because they don't have any disease that's causing any interdental bone loss. He just has some recession right here. And this case on the bottom is very different from this case on the top. It's important to know the difference. So when do we intervene for recession? All right, so when do we recommend treating? There's a couple reasons why when a patient comes in to see me for recession, why I would recommend treating them. The first thing is aesthetic concerns. So oftentimes patients come in, they don't like the root color, right? That gold, yellowish root color. In contrast to the crown and in contrast to the gum tissue, they don't like the tooth length, right? The teeth are looking longer, especially the canines especially. You see this a lot in the maxillary anterior teeth when there's disharmony in the gum tissue, and that's kind of the third reason as well, is some of the gum tissue has proceeded apically while others haven't, and so when you smile, it just doesn't look very even and harmonious. So aesthetic concerns. If the patient has an aesthetic concern, that's a reason to go forward and recommend treatment. Cervical lesions, right? So a patient brushes really hard, they have a carious or non-carious lesion that's caused by the recession. So typically like a class 5 lesion, right? That every dentist would just love to fill. These actually can be treated by a soft tissue graft. Now, if there's a carious lesion there, we might need to do a restoration, a very moderate or minimal restoration in order to resolve the caries. But we can actually, instead of just filling that entire area with composite or extending a crown crown apically onto the root surface, we actually can perform a gum graft to actually advance that gum and cover some, if not all, of the root surface, and actually get a much better harmonious result and a much more natural result that can cover that sort of defect. So that's another reason why I might be interested in treating some recession. The last two things here, last two reasons why you treat dental recession: dentin hypersensitivity. I'll be honest with you, I've never had a patient come in that said, my teeth are really sensitive and I recommended a root coverage procedure for this patient. You just don't see it a whole lot. And honestly, there's better ways to treat the dentin hypersensitivity than to do a very expensive gum graft, but it is an option out there. And finally, documented progression of recession. So if you saw a patient 2 years ago, they had a little bit of recession, you see them in your chair tomorrow, and that recession has gotten worse, there's a reason why that's happening. Now, the fact that it's getting worse in and of itself, right, I'm not too concerned about, right? Because we talked about you're not going to lose a tooth due to recession. But what it does concern me is when we continue to have more progression of that recession, the keratinized tissue that's at the apical aspect of that recession there, as we continue to have recession, that KT is going to start to degrade and going to start to go away. So we might have 2 millimeters of KT 2 years ago, but as that recession continues to get worse, we might only have 1 millimeter, or we might actually blow through all of the KT and just left with alveolar mucosa. We know that a patient has a higher likelihood of further recession and inability to keep that area clean if they have alveolar mucosa and not thick keratinized tissue. So if I see a patient and they have continued progression of recession, that is another reason why I might say, you know what, we probably need to recommend treatment here to reverse this and not let it go in the opposite direction we want it to and cause detrimental effects down the road. When to intervene for KT width, right? So you got a patient with minimal KT. We've already kind of talked about this. We don't automatically recommend a treatment for every patient with, less than 2 millimeters of keratinized tissue. There have to be certain things that I observe in order for me to say, yes, this is something I need to treat. That first thing here is the inability to clean the gingival margin. We saw some photos of this already. We see that there's inflammation that's uncontrolled. We see that there's tissue sensitivity when they brush. They complain, it hurts when I brush this area. We see that there's plaque accumulation. They're not able to keep this area clean because they don't have that good band of thick tissue there. A lot of times we can also see deep pocketing, especially on the buccal, right? So there's no KT and there's a deep pocket right there. There's clearly some inflammation that's going on that's uncontrolled. We already talked about this as well. A second reason is orthodontic treatment, right? So a patient comes to you and says, I'm about to have ortho treatment, or you're about to initiate ortho treatment on a patient. If you look at those teeth and the teeth that you're going to be moving, and if there's no KT or minimal KT on those teeth, that is something that you should be thinking about recommending treatment for to augment that soft tissue so we don't have a recession as a result of the beautiful ortho treatment that patient is going to have. And finally, you'll notice here at the bottom, documented progression of recession. Same thing as with recession, right? We talked about this is one of the reasons why I would recommend treating a recession defect. Same thing here. If I've got a patient who has no KT and they've got recession and it's continuing to get worse, that KT is already gone. And there's going to be a high likelihood of not only more recession, but uncontrolled inflammation because that patient just can't keep this area clean. Because of the fact that as the recession increases, the KT width decreases, I'm likely going to recommend a treatment to augment the soft tissue or cover the root surface, depending, if I see a patient with minimal KT and a recession that's getting worse. So those are reasons why I would recommend treatment for both recession and minimal KT. What happens if you do nothing? I think it's important to always tell a patient that, right? We always talk about risks, benefits, alternatives. And so what happens if you do nothing? Well, there's a couple things, right? Obviously, if your patient has recession or if a patient has no KT and some inflammation, well, the best case scenario is there's no worse progression of recession, right? Everything just kind of stays the same. That's probably the best case scenario. But in reality, what also could happen is the recession could progressively get worse, right? We could have increased root surface show. So aesthetically, you could have a result where the patient just doesn't like what they see and it continues to get worse. We also are going to have a degradation of that KT width as the recession gets worse. And I think the ultimate worst state that could happen is that we have increased gingival inflammation, right? I don't want any inflammation in the mouth, period. And you shouldn't want that either. And so any opportunity we have to avoid that and to correct or prevent any gingival inflammation, especially uncontrolled inflammation in areas with a lack of KT and recession, that is something I would recommend that we get treated. And so it's important to tell patients that, you know what, I see some recession, I see a lack of KT right now. It could be nothing. We could just monitor this and see what happens, but there's also a likelihood that this could get worse. Or I'm seeing signs from 2 years ago versus today that the recession is getting worse and your KT is actually getting smaller. Or I'm seeing that you're unable to keep this area clean and we actually have some uncontrolled inflammation in this area. We need to be able to see and recognize what those defects are, how they're progressing, and then be able to tell the patient, if I do nothing, here's what could happen, and here's where I think it's going to go, and why we should treat it now versus just monitoring it and just seeing what happens, right? We know that there's potentially some pretty bad consequences if we just let it sit there and just watch and monitor and see what happens. So it's always good, I think, to just tell the patient right up front all the things that could happen, from the best case scenario to the worst case scenario, and then you can have a conversation and see what's the best for the patient. So when to intervene, this is just a review here. You can take a snapshot of this if you want. Gingival recession, there's 4 reasons why I recommend treating gingival recession. Right? Aesthetic concern, dentin hypersensitivity, cervical lesions, or documented progression of recession. If the patient doesn't have any of these, then they're fine with recession. They'll be okay. They're going to be okay. But if they have an aesthetic concern, if they have sensitivity, if there's cervical lesions there, this is typically kind of tied to aesthetic concerns. Or if the recession is getting worse, then these are reasons why I would recommend at least having a referral to a periodontist to see if what can be treated. Lack of KT width, again, same thing here. Just because they have lack of KT, less than 2 millimeters of KT doesn't mean that it's going to be an issue. But if I start to see the inability to clean the gingival margin, uncontrolled inflammation, that's something for me that I would say we need to treat this and intervene. If they have a scheduled orthodontic treatment with a lack of KT, again, I'm going to highly recommend that we treat that as well. And finally, a documented recession progression with a lack of KT, that's something where I'm going to say, yep, you know what? We need to go ahead and intervene and treat this as well. All right, so we've talked a lot about treating these recessions, right? And I've mentioned a couple times when I would recommend treatment and when I would recommend not treatment. When we talk about treatment, though, obviously from your perspective as a dental hygienist or a general dentist, you might not be the one actually doing the treatment. So when I say treating, in many cases, it likely means at least referring to your friendly neighborhood periodontist who will likely actually perform the soft tissue grafting. So what I wanted to do real quick in this slide is just talk about what are we as periodontists looking for and looking at when we get a referral from someone like you who suspects that there's a gingival defect, a soft tissue defect that you've identified, that you say, you know what, I think we need to treat that. So let's take a look at this here. A couple things that we are going to do as periodontists to understand what's going on with the patient and how we're going to evaluate them. First off, I'm going to evaluate the gingival defect etiology, right? So patient comes to me either with recession, a lack of KT, maybe both. I'm going to understand, okay, what is causing this gingival defect, whether it's recession or a lack of KT. I'm going to look at, does the patient have periodontitis, right? And if they have periodontitis, obviously I'm going to recommend that we treat that first. Now, hopefully this is something that you've identified in your office, in your practice, and hopefully has been addressed as well and treated in your office. Obviously, you are very well capable and aware and able to identify and treat periodontitis. So if that's something that's going on, if that's the reason for recession, obviously I want to treat that infection and inflammation first before we move on to anything else. The next thing I'm looking for is there any modifiable behaviors that are the etiology of this gingival defect? So if there are, for example, toothbrush abrasion, right? That's probably one of the most common things that we see. If there is a toothbrush abrasion or some other modifiable behavior like flossing or toothpick, for example, things like that, I want to educate the patient on that, tell them this is what I'm seeing, this is probably why this is being caused, and then help them modify their behavior, get them on an electric toothbrush, show them how to brush properly without a lot of excessive force on the gingival tissue, that sort of thing. I'm going to modify that, and I'm going to want them to come back and show me, is the recession continuing to progress, or if we modify this behavior, is that actually solving the problem? Now, there are some cases, of course, where there's non-modifiable factors that are causing the recession. So that could be a non-carious cervical lesion or a carious lesion. It could be just due to the fact that that's just the way that they're made. They have thin gum tissue, a lack of KT, orthodontic treatment maybe had moved the teeth out of the buccal housing, and there's nothing we can do about it except for augment the keratinized tissue. In that case, of course, I'm going to educate the patient on what I'm seeing and also recommend any sort of specific treatment. So once I understand the etiology of what's going on and what's causing this gingival defect, then I'm going to do our perio-nerdy stuff, which is to understand the recession or the soft tissue defect extent. I'm going to provide a classification for what I see. So this is kind of like our diagnosis. And then obviously weigh that and understand that with the patient wishes and patient desires. What does the patient ultimately want? with respect to this gingival defect. After we've educated them, after we've seen what the progression of the defect is, how bad it is, that sort of thing, it's extremely important for me to inform the patient on what I'm seeing and what the extent of the recession is. Is it just minor? Is it moderate? Is it really severe? Is it really bad? Is it something that really needs to be addressed? One of the things, especially with recession, that we see is patients come in, they obviously have aesthetic concerns that they want to have addressed. And so one thing from a periodontist perspective is being able to predict and tell the patient how much of the root surface that's exposed do I think I could cover with a root grafting procedure. And there's a lot that goes into that. We're not going to cover that in this video, but that is something I'm going to talk with the patient about. I'm going to make sure that they are aware of what the limits are of our treatment. And if I think I can get 100% root coverage, or if I think I can only get 75%, I'm going to tell the patient that. And I want to make sure that they are very aware of what I think the results are going to be before they invest the time and the money to go through with the treatment. And obviously I'm going to tell them about my treatment approach, what I recommend, whether maybe it's a connective tissue graft, maybe it's a coronally advanced flap, right? I'm going to tell them what the different treatment options are, and I'm going to select my treatment approach and tell them that. I'm also going to evaluate from a soft tissue thickness perspective. I'm going to evaluate their soft tissue thickness, and I'm also going to understand the patient wishes. So this is for something where maybe there's just a lack of KT, they're unable to keep this area clean, there's uncontrolled inflammation. I'm going to classify their gingival phenotype. Is it a thick phenotype or a thin phenotype? We have ways to do that. I'm going to determine where augmentation would be beneficial, right? I don't necessarily have to augment every area with a lack of KT, 2 millimeters or less, but there might be some areas where I say, this area right here, you can see the inflammation, you can see the plaque. I know it's probably sensitive to you. This is an area where I think we need to augment the tissue. These are areas maybe we need to monitor, but don't necessarily have to treat. I'm going to tell the patient all of that. And then finally, I'm going to recommend a treatment approach as well. So maybe a free gingival graft, which is a very common procedure for something where we're addressing the soft tissue thickness. That's what we're going to go ahead and do. So that's just in a nutshell what we do as periodontists when a patient comes to me and says, hey, I've got this gingival recession, or I've got my dentist said, I need to come see you because I've got some gum issues. That's what we're looking for. That's what the consult's going to essentially do. And that's how we're going to proceed with moving forward with treatment for the patient. Now, when we talk about moving forward with treatment, I just want to go through a little bit in this presentation about soft tissue grafting options. And specifically, we're going to address recession and soft tissue defects with a lack of KT through root coverage procedures as well as tissue augmentation. So you can see here in this photograph, we can use allograft right here. And this is a donor tissue. We also have the option to use autogenous tissue here. These are all my photos of cases that I've done. I'm going to briefly just go through a couple cases here to kind of show you the art of the possible, some of the things that we do, some of the ways that we address either root coverage or tissue augmentation. So first thing here, just a couple photos here to kind of show you from going from top left to bottom right as this case progressed. You see here, we actually have seen this case before, right, in this presentation. Beautiful case of recession here on one single tooth on this premolar here. I performed a tunnel procedure where I essentially tunneled underneath the gingival tissue from the tooth in concern, also with the tooth distal and mesial to it. So we have a patent tunnel around this tooth, and you can see that I can actually advance the gum tissue up coronally. In this case, with the perio probe here through that tunnel. I harvested a connective tissue graft. This is autogenous connective tissue here from the roof of the mouth. And then I sutured it underneath that tunnel over the gingival defect and was actually also able to raise the gum tissue up to cover over that defect as well. Do some fancy suturing here. This is 6-0-proline. And then about 4 weeks later, patient comes back, sutures are out, and this is what we see here, 100% root coverage and resolution of this defect. If you were to look from the occlusal or take an occlusal photo here, you'd see that this tissue actually is very nicely bulked out as well, and that's a result of the connective tissue graft. Another case here for root coverage that we did. So this patient came to me, she really didn't like just a little bit of recession that she had here on 7, 8, and 9. Those were her primary teeth of concern. You can appreciate here she actually had some class 5 restorations in the past. This tooth here, number 8 on the straight facial, you can see a little bit of that residual composite. We see that here on number 7. The composite on number 9 had actually come out previously from that class 5. So she doesn't like the root color. She just would like the natural appearance of her teeth and would like that gum tissue to cover over that exposed root surface. So here I also performed an autogenous connective tissue graft procedure. This is the autogenous connective tissue graft that I harvested from the roof of the mouth. I did perform a modified tunnel procedure. It's called a VISTA approach, kind of a similar approach to last time where you tunnel underneath the gum tissue and then we feed this connective tissue graft underneath the tunnel, underneath the gum tissue. And then going up here to the top right, you can see all of the suturing here where we advanced the gum tissue with the connective tissue graft underneath it to cover over all of those defects. You can see that we've advanced the tissue up over that class 5 composite on number 7. Patient came back a few weeks later, took out the sutures, extremely happy with the results. For 7, 8, and 9, you can see that we advanced the tissue coronally. It's very bulked out here, and you can see that we've covered over all of the root surfaces. Patient was very happy with this result here as well. So for recession, those are 2 case examples of just how we would cover the root surface and address a chief complaint of poor aesthetics and just wanting to be able to cover the root surface and have more of a natural appearance and a natural smile. Now let's look at gingival augmentation, right? So this is a case, we've actually seen this before as well, where this patient came in with basically no keratinized tissue here, a lot of bleeding, a lot of uncontrolled inflammation, plaque at the margins. In this case, we did not do a connective tissue graft, we did a free gingival graft. So you can see here on the bottom left, the tissue bed that's created here. You can actually see there's a dehiscence on tooth number 23 as well. And even though there's maybe just a little bit of recession here on 23, we can see clinically, obviously 24 and 25, we can see some recession here. We can appreciate that there's still actually some bone that was lost here on the buccal of number 23, and that was due to ortho. This patient had prior ortho. She actually has a lingual retainer that you can see as well. So I harvested a free gingival graft from the roof of the mouth here, just over 10 millimeters wide, and I believe it was about 28 millimeters in length. Sutured it to the gum tissue over the soft tissue bed that we created here. The soft tissue bed was split thickness, so it has blood vessels to nourish the graft. This picture right here is 2 weeks post-op. Really looks good at 2 weeks. You can see all the residual sutures here that are going to be removed. And then the patient came back about 2 months later, and this is what we see here. Beautiful result. Pardon the saliva bubbles here, but we have actually complete root coverage over 23, 24, and 25. So we actually resolved the recession, which doesn't always happen with free gingival grafts. So really nice benefit there. Most important though, we have a very nice thick band of keratinized tissue that's going to be easier for the patient to clean and also going to resist future recession. The one thing to note here is in between 24 and 25, we do still have that black triangle here. We're not going to be able to resolve that. If you were to look at the x-ray, you would see that this patient has interproximal bone loss between 24 and 25, unfortunately, likely due to the fact that we had uncontrolled inflammation in this area, a little bit of periodontitis. So obviously cleaning and scaling and root planing in this area was very important prior to starting to address that periodontitis. I don't believe that she's going to have any further issues now because she has this good keratinized tissue here. So that's an example of gingival augmentation. Now let's move over to grafting options. Pull up this slide here. I talked about right in the beginning, right? We have autogenous tissue grafting, so that's for connective tissue grafts or free gingival grafts. We also can augment soft tissue using something called alloderm or an allograft material. This is tissue that comes from a donor, and it was originally developed for burn victims and has actually been applied to dentistry very well. We can apply it in a very similar way to a connective tissue graft underneath the gum tissue. In both of these cases here, I did tunneling techniques where this alloderm was tunneled underneath the gum tissue that was lifted up off of the bone. We can see a very good effect and similar efficacy as autogenous tissue when it comes to what we call phenotype modification, which is just a fancy word for thickening that gum tissue. So allograft, alloderm is another option that we can use in some of these cases as well. I don't prefer it. It's definitely not the gold standard, but it can be a good option for patients who really are adverse to having the tissue harvested from the roof of their mouth, or for patients who maybe are smokers who have a poor tissue quality up at the roof of the mouth, or just have super thin palatal tissue. This can also be a good option for them. All right, so the end of the presentation here, I just want to go through a couple case examples to really just kind of tie everything together. We've talked about the gingival defects, we've talked about when to treat, why to treat, and I've shown you a couple examples of how we treat that. What I want to do just to wrap things up is to go through a couple case examples just to kind of tie everything together and help us bring all these concepts of when to treat, why to treat, and go from there. So first case here, let me tell you what, this is a very difficult patient, and I know personally because this is actually me. This is a picture of my mouth here, and so you can see there's a lot of stuff going on here. Chief complaints, when this patient comes in is I'm just here for a periodic exam. Right? So they're not aesthetically driven. They don't mention anything about the recession or anything like that. And I do apologize, it's a little bit of a dark photo, but let's just take a look here. Do we see any gingival defects, right? So remember, this is kind of the point of the presentation, is to help you be looking at these patients and having an eye for gingival defects. So as I look here, yeah, I do see some gingival defects right off the bat. I mean, right off the bat, 8 and 9, the gingival zenith is not harmonious, right? Number 9, actually, the gingival zenith is more apical than number 8. From a as a periodontist, that bothers me, right? I see that right away. I also see a very large disharmony between number 7 and number, what I think is 10. It's actually number 11. I was born without number 10, and so this is actually number 11 that was moved into number 10's position, so that's why we see the gingival zenith disharmony there. I had a dental school classmate actually kind of reshape this with some composite to try to look more like a lateral incisor as opposed to a canine, and actually did a pretty good job considering my face. So we have some issues there. We can see some recession a little bit further down on some of the upper premolars here. We go to the lower arch, same thing. We see a little bit of recession here on these premolars, even coming right across here on the anterior, right on the mandibular incisors. We can definitely see maybe 1 millimeter of some recession here, a little bit on the canines as well. So instantly what's jumping out at me is I'm seeing some aesthetic concerns, right? I'm seeing some gingival disharmonies. I'm seeing some recession as well. And so as a dentist, right, if I see this, I would want to bring this to the patient's attention. Say, I'm looking at your mouth, I'm looking at a couple of things. Can I just show you what I'm noticing? And, show them a photo of the recession, show them a photo of the gingival disharmony. Ask the patient, does that bother you? Now in this case right here, the patient, myself, I'm not aesthetically driven. When I smile, I don't see these. My smile line isn't super high, so I actually don't really appreciate or notice the gingival disharmony when I smile. If I did show that, I'd probably be actually a little bit more concerned. So I don't care about the recession, right? For me, from an aesthetic point of view, that's not a chief concern of mine. The recession, I will tell you, is also not getting worse. All this recession was actually driven by when I was in my early 20s. I brushed like a maniac for like 30 seconds, right? This is well before dental school. I didn't know how to brush. I brushed super hard with a really hard toothbrush, and that's what actually caused a lot of this gingival recession. I actually had a little bit of mild periodontitis as well. Probably way more information than I should be sharing. But the point is, the gingival recession here, after I figured out what was going on, had my periodontitis treated, and was told how to brush with an electric toothbrush using a soft bristle, this recession has actually not gotten worse for years, and I've been monitoring it. So in this case, the patient isn't concerned about it aesthetically, and it's not getting any worse. There's not any uncontrolled inflammation. So in this case, I wouldn't recommend any treatment, right? Because there's no reason for me to move forward, even though there are some gingival defects. Patient isn't going to lose any more teeth. They're not at risk for any inflammation. So I'd leave it. I'd let the patient know what I'm seeing, plant the seed, and maybe in the future they're going to be concerned about it. But right now, I wouldn't recommend any treatment, even though I see a couple gingival defects. All right. So that's case number 1. Case number 2, let's take a look at this patient here. So chief complaint, chief concern is she comes to see me and says, I'm having orthodontic treatment soon, and the orthodontist is wondering if I need grafting. Well, first off, I want to tip my hat to this orthodontist and say thank you for considering the soft tissue before you start moving teeth, because yes, this patient does have some issues. Let's take a look here. The top arch, I'm not too concerned about anything. Gingival tissue, the thickness of the gingival tissue looks great. Her gums are healthy, good bone levels. I've looked at the x-rays and everything looks fine. But I come down here on the bottom, instantly what's jumping out at me is number 23. I've got a little bit of recession here. Okay, patient isn't too worried about it. She doesn't express any concerns. But what I'm seeing is recession and a lack of keratinized tissue all around these mandibular anterior teeth. I can appreciate that there's crowding. There's going to be a lot of orthodontic movement that's going to happen for this patient. So first off, I'm recognizing a gingival defect of recession, and I'm also recognizing a lack of KT around these teeth. She's going to have orthodontic treatment soon, so this is a case absolutely where I'm going to recommend gingival augmentation treatment to augment and thicken this gum tissue, either with a connective tissue graft or a free gingival graft. We could go a couple different ways, and I think both have good options, good outcomes, in order to thicken this gum tissue so that we prevent recession in the future after the orthodontic treatment and after all these teeth are going to be moved around. So yes, I would absolutely recommend treatment, not only to address the recession, but also mostly for phenotype modification, thickening that gum tissue. That's how I would approach this case, right? An orthodontic case, lack of KT, some recession, definitely indications for treatment. All right, case number 3. Man, take a look at this. I mean, this jumps out at you, right away. Patient comes to you like this. What are you going to recommend, right? So chief complaint, chief concern. I don't like how long these teeth look, referring to her mandibular anterior teeth, 24 and 25. And I'm worried that I'm going to lose my teeth. Well, first off, let's make sure that we comfort and reassure the patient that you're not going to lose these teeth due to recession. Okay, so make sure that she's aware of that. That's our job as professionals, is to educate our patients. But number 2, right, so let's take a look and see, what are some of the defects. And it's not a good photo of the top. I'll just tell you the top looks fine. But the bottom, right, what jumps out at you, right? Well, obviously the recession here on 24 and 25, right? We've got about 4 or 5 millimeters of recession at least. When I look at the KT as well, I see, gosh, There's no KT around 24 and 25. It's hard to appreciate here, but there was some plaque at the margin. It's hard for her to keep these areas clean. You ask her, she says that these areas bleed and it's very sensitive. Would you treat this defect, right? It's not only a recession defect, but it's also a lack of KT in this area. I would hope that the answer is absolutely yes, we need to treat this. It's gonna get worse because there's a lack of KT. We see that there's uncontrolled inflammation. This is going to get worse. It's hard for her to keep it clean. There's uncontrolled inflammation. Absolutely, 100%. This is something that I would say, yes, we need to refer to your local friendly periodontist. We need to get this treated. That's how I would treat that case. Hopefully that's very clear to you that we see a progression of recession. We see uncontrolled inflammation, lack of KT, boom, boom, boom. We definitely need to treat this. All right, and let's go to case number 4. Wow. Okay, you take a look at this. This is a great patient of mine, and you see a lot going on here. Okay, this is a kind of a complex case. So chief complaint, chief concern. My dentist said I should come to see you. She's not aesthetically driven, right? So she has no idea really why she's here, except for the fact that she was told that she needs to come see a periodontist. So this gets back to the educating the dentist and the hygienist, and that's the whole reason for this presentation, is to help you as a dental professional educate your patient on what you're seeing, being confident in your diagnosis and saying, I'm thinking there's a gingival problem here, and I think you need to go see our periodontist because there are some treatments that they can perform to either thicken the gum tissue or cover the root surface, right? If you have that conversation with the patient, then they come to the referral much more informed and ready and willing to hear what different treatment options are. So again, just kind of a plug for why it's important for you to be confident in understanding these gingival defects, recognizing them, explaining them to your patient, and also understanding a little bit about some of the treatment options that might be available that we're going to talk about with respect to the consult with a periodontist. So let's go back to the case here. She's, you look at this on the upper arch here, I see a recession generalized, and it definitely looks like this is the product of, a year's worth of periodontitis, right? We see interdental clinical attachment loss. Obviously we have some bridges here as well, right? 8 and 9, that just jumps out at you like, man, there's some good keratinized tissue here, but yep, we definitely have some recession going on here, likely due to the tooth loss on the laterals. I will tell you that this patient is stable from a periodontal perspective. So she had periodontitis prior. It's stable now, and that's part of our evaluation, is to understand that etiology and make sure she's stable. And obviously, if she wasn't stable, we'd treat the perio first. When it comes down here to the bottom, what am I seeing that really jumps out at me is a lack of KT. In addition to the recession for teeth, really the anterior teeth. So 23 through 26, especially 24, 25, right? We have almost 1 millimeter of keratinized tissue. It's not attached to the bone. It's, because this pocket depths here are about 2 millimeters. And so for me, I see a progression of recession. I see a lack of keratinized tissue. This is a case where I would recommend in this case, a free gingival graft treatment for her and make sure that we have that good thick band of keratinized tissue that's attached to the bone that's going to help make sure that we keep this area clean and prevent future recession. Now, with respect to the recession up here, she's not aesthetically driven and her perio is stable. There's no reason that this recession is going to progress, right? As long as she's using a soft toothbrush, brushing properly, using an electric toothbrush, hopefully, and looking at her prior perio charts, which I had the ability to look at from her years being at the dental school, I was able to see that, for the most part, her recession here is pretty stable. It's not advancing and she's not aesthetically concerned. So I'm not going to really be focusing or recommending a gingival graft procedure, especially for 8 and 9 here, even though I see it and I think that, we could do some treatment here. Patient doesn't need it. Patient doesn't really care for it. It doesn't bother her. So I wouldn't recommend or go forward with a treatment for 8 and 9, but I certainly would recommend treatment here for the mandibular anterior just because of that lack of KT and the progression of recession that we've seen over the years. All right, last case here, case number 5. Chief complaint for this patient is I can tell I have some gum problems on the lower. My teeth look longer. This patient is aesthetically driven. So let's look at the top arch here. Everything looks pretty fine. There's a little bit of recession here on some of her premolars. We're not going to focus on that too much, but we do see that here going on the bottom teeth here, where the teeth of concern especially. We see 23 through 26, some recession. Actually, the worst here is 23, and then it kind of gets progressively better until when you get to 26. So obviously we've got some recession here. The patient's concerned about it, exposed root surfaces here. In addition, we can see that there's essentially no keratinized tissue here on the buccal as well. So is this a case that you treat? Hopefully you're saying yes, absolutely, because there's a couple things that we're checking the box for. Number one, we have recession, and the patient is aesthetically concerned about it. Number two, we have a lack of keratinized tissue, and the patient is telling you that the recession has gotten worse over the years. In fact, she had ortho treatment about 2 years ago, and so as I'm feeding you information, hopefully that's even helping cement this in even further. The recession didn't used to be this bad, but over the past couple of years, it's gotten worse. So she has progressive recession, lack of keratinized tissue. Those are two things, boom, instantly I'm thinking, yes, we need to go ahead and treat. In this case, from a perio perspective, you could do a free gingival graft. That could be an option here. I think I would elect to do a connective tissue graft to really thicken that gum tissue and try to advance some of this tissue coronally to cover some of the root surface. I'd make sure to tell the patient I'm not going to be able to cover all of the root surface. I can see just from the photo, not even looking at the radiographs, although the radiographs will support this, that there's interdental clinical attachment loss for all of these anterior teeth. You can appreciate the black triangles here in between the teeth that just tells you that there's a lack of interproximal bone loss, right? We've had some horizontal bone loss, so that's going to limit my ability to bring that tissue coronally to cover the root surface. So I'll have a conversation with the patient and tell her, but I'll say that the advantages of still doing a treatment, even though I can't cover all that root surface, the advantage still is that thick gum tissue that's going to be resilient to future recession and also will help her keep this area clean for a long time. So those are 5 cases that I've treated that I just wanted to bring up and kind of share with you, help walk through my thinking, kind of try to tie some concepts together. Hopefully that was helpful for you. All right, so rapid fire summary on what we should take away from today's presentation, what I hope you're walking away from. First off, be on the lookout for gingival defects, specifically recession and the lack of KT width. You know what they look like. You've seen a bunch of case examples. I guarantee you, you are now much more educated and can be confident in seeing these defects and recommending them to your patients. Number 2 is understanding the etiology of soft tissue defects, right? You are smart enough to know what is causing some of these things. And you might not know exactly what it is, but you might be able to narrow it down to a few things. Maybe it's toothbrush abrasion, maybe it's prior ortho treatment, maybe it's just the way that they were made. It doesn't matter, but we just need to understand what that is, right? Understanding that periodontitis can play a role in this, and that needs to be addressed in addition to treating these soft tissue defects. Now, why would we treat recession? Let's just review: aesthetics, progression of recession, sensitivity, cervical lesions, right? If we see any of those things, those are reasons why I would say as a clinician, I need to refer you to a periodontist for treatment, or as a periodontist, why I would recommend treatment. With respect to keratinized tissue, why would we treat that? A lack of KT defects are important if we see uncontrolled inflammation or recession progression, right? Those are big things for me. If I see a lack of KT, those are the 2 reasons why I would recommend treatment. Otherwise, I'm going to leave them alone. Finally, I think it's important to help the patient understand the nature of the referral. Why are you referring them to see a periodontist? What are the defects you're seeing, and why does it matter? You've got the tools now from this presentation to hopefully at least be confident in understanding your recognition of these defects and helping the patient understand what the consequences of not treating and treating these defects are. So hopefully that was helpful for you. Thank you so much for watching. If you have any questions, please reach out. I would love to be a resource for you if there's a specific case you'd like me to help you with, or if there's a more detail or more information I can provide with respect to soft tissue, how we treat it, different classifications. If you want me to go into that, I'd be happy to do that as well. Thank you so much for treating our patients and taking care of their gingival health. It's super important, often overlooked, and you are a huge part in making sure that we optimize the oral health of our patients.